Before we begin this Geri Pal podcast, we'd just like to say a special thank you to those who recently donated to the Geri Pal podcast more than $100, including
Ken Longa, Carrie Levy, Marnie Fetzer, Ron Sabar, Stephanie Gabatuller, and Patrick Lally.
If you want to donate, click on that little donate button on the geripal.org website. And on to the show. Welcome to the Geri Pal podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who do we have with us today?
We are delighted to welcome Houman Javedan, who is a geriatrician and director of inpatient geriatric medicine at the Brigham and Women's Hospital, where I trained, and associate program director of the Geriatric Fellowship at Harvard Medical School. Houman, welcome to the Geri Pal podcast.
Thank you. This is very exciting for me. I've been listening to this podcast for a while.
We love to hear that. We're also delighted to welcome back Vicky Tang, who's a geriatrician, researcher, and coach. Listen to our prior podcast with Vicky about coaching. And she is at the University of Texas, Houston, where she is the Roy M. and Phyllis Goff Huffington Chair in Gerontology. Vicky, welcome back to the Geri Pal podcast.
Thank you.
So we got a lot to talk about. We're going to be talking about perioperative or preoperative assessment in older adults. But before we get into that topic, we always do a song request. And I think you have a song request for Alex.
Yeah, there's a song by Alex Cuba called Ahora, which, there's two reasons I explained I really like this song. The first phrase says, I'm loyal to the life that I have chosen, which I think represents sort of the feeling a geriatrician has mid-career and onwards. And the second, which was interesting, was Alex Cuba himself said it took him 13 years to complete this song because he sort of learned to be present in the time and sort of appreciate that sort of geriatric wisdom about the now and not being worried about the future.
Beautiful message.
Have you been practicing this song for 13 years, Alex?
I have not. But I did record it for those of you who are listening to the audio only with my sons Kai on ukulele and Ren on bass. And here I'm going to try it on guitar. We'll see what happens. Sigo siendo fiel a la vida que he escogido. Sigo sin saber, abrazando al destino. La fe de una mirada, la luz de la mañana se hacen testigo de mi propio ser. Que del tiempo es un cautivo. Difícil de entender, me suele suceder que tan solo en el futuro puedo ver felicidad, porque no puede ser ahora. Ahora.
That was great, Alex. Thank you.
Wow, well done. I'm impressed.
Apologize to those of you watching on YouTube.
I kind of want to hear the ukulele version.
Yeah, it's much better. Listen to the audio only.
Who's playing the uke?
Kai's playing the ukulele. And I forgot to bring my ukulele to work. You forgot your notes.
I forgot
We're winging
notes.
it today.
Yeah.
We are winging it,
What are we
listeners.
talking about again? Pre-operative assessment. I got a question. And we actually got some questions from our listeners. But I think the biggest one is, why do we even bother with this? Why do we do preoperative assessments? Is it just like a legal formality? We're just saying, hey, like, you know, we've cleared this person for surgery, or is there more going on here? Houman, I'm going to start off you. Your thoughts on that?
Yeah. So I guess I'll sort of need to share that I started life as a surgeon, right? And I need to share the couple of anecdotes that sort of I love geriatrics in med school. Then people said, no, you don't want to do that. And then I really enjoyed the teamwork on surgery and being in the OR. And then started life as my basic surgical training was in Scotland, so in Edinburgh and Glasgow. But it was always the older patients where I felt like it didn't make sense. People were missing things and people were very binary about it. In my days, it was this attitude of like, you don't operate on anybody over 85, or you do absolutely everything. And if they don't do well, they were old. And I specifically remember one case where was a little bit traumatizing. There was a general surgeon in Glasgow who would sort of haze his fellows by bringing in sort of terminal patients, and they wouldn't last very long. And I broke rank. I broke rank and confronted him. And he said, well, they were old. They're going to die anyway. So like, and something just sort of in me said, no, that's it. I can't do this. Like, that's not a good enough answer anymore. So I really sort of leaned into aging and sort of geriatric assessments for surgical patients. And 13 years later, that's kind of my career. To basically, the answer to your question is, it's not just a legal thing. It's actually identifying the amount of aging and disease a patient has before you subject them to surgical insult so that you can have the best outcome. And that is the core of all of it. It's sort of like, it's taken me 13 years to be able to come and say this in a podcast, but that is really the answer. Is surgeons just don't know, like, nobody has that training and skill, the geriatricians, to really assess the amount of aging and disease that a patient may have, so they can then decide what the surgical insult will do, and if it's appropriate, inappropriate, and how to modify it, which is what I'm more interested in going forward. So is how do we do it better?
So should we do surgery or should we not? But even more, like, if we go ahead with the surgery, how do we actually improve their outcomes by thinking about it beforehand?
That's right. And there's a lot you can do in the OR. There's so many things you can do. Like, there are surgeries that may be appropriate for a 50-year-old, but inappropriate for the same functional outcomes in a frail, like, 85-year-old. Like, you can get the same functional outcomes, but the actual surgery and interventions are different to get the same outcomes.
Yeah. Vicky, you've done both outpatient preoperative assessment in older adults. You've done doing inpatient preoperative assessments in older adults. How do you think about the why question? Why do you do it?
Yeah. So I'll actually share what my surgical colleagues tell me is they feel very uncomfortable doing surgery on older adults and not being certain that they're going to get the outcomes for the patient that the patient would want, right? And so they're not sure how to have these conversations. A lot of surgeons are the ones that were referring to me in the pre-op
maybe
clinic.
A select group of people who are referring to you.
Yeah, they're like, I don't think the outcomes are going to go well. I don't really know how to assess, what's going to happen to this older adult. So I'm just going to refer to geriatrician, and geriatrics will, kind of suss it out. And so I'm like, yeah, sure. Thank you. And using that opportunity to, like what Houman was saying, there's a lot of stuff we can optimize before surgery so that we can, increase the, likelihood of a positive outcome in older adults, and have the conversation about, what's most important to the patient and how does this surgery potentially impact that? Does it actually fit with, what the goals of the patient is, and deciding, hey, maybe surgery is not the thing to go. Maybe there's something else to offer. So, yeah, that's what I would say.
Maybe for our audience, we can take a step back. Probably a lot of people have, either done or seen kind of preoperative assessments. What's different in older adults when we think about the preoperative assessment? Houman, I'll start off.
Do you want me to go first?
Go,
yeah. So it actually kind of tags along beautifully from, sorry, I've listened to a number of your podcasts, but the comprehensive, for those, I'm going to plug it. Whoever didn't listen to the comprehensive geriatric one, go back and listen to that one, because the comprehensive geriatric assessment, I think, is critical to the role of elucidating the value of the knowledge base of geriatrics and geriatricians. And the key element, I think, is this. I've sort of had the privilege of working with Ken around developing our frailty index, where I view it as a Trojan horse for a CGA, basically. If you can sort of come up with an algorithm for a CGA on your sort of deficit accumulation frailty, it's a way of sort of communicating to others your CGA in a numeric manner.
And for all our listeners, CGA is comprehensive geriatric assessment.
Yes, thank you. Sorry. So to be honest, I think it's the multi-domain evaluation, which includes function, cognition, comorbidities. And then I would say that in the case of surgical assessment, what you really want to know is how much are those comorbidities actually subtracting from the physiological reserve of the patient. So the ultimate answer when you finish is what is the physiological reserve of the person in front of you, and how much of that reserve is determined by a disease process, and how much it is determined by their unique aging and where they are in that sort of physiological journey. And once you have that, then you can sort of look at, okay, what sort of insults can this person tolerate? And it sort of fits in with a lot of these notions about, with frailty, we have notions of resilience, which is recovering from injury, and then the robustness, which is sort of the antonym of frailty. Like, are you robust enough to tolerate? And then what you can do is choose the surgical options that are there. You can take some surgical options maybe are beyond, like, I'll just talk about orthopedics, which I know best. So a good example is someone may need a revision surgery, or someone may just need sort of an open reduction and fixation with plates and screws, which ends up with a much less sort of surgical insult compared to a major revision, which would be you have to hammer all the hardware out, sort of align everything and hammer everything back in and cement it in place, which is a much bigger insult. So I would say in the most simple way, that is sort of what the geriatric assessment does. But I do want to say that the downstream, it can't sit on itself in isolation. I have a very close relationship with my surgeons, and we both speak our language now of, once you do the assessment, they tell me what the surgical sort of variety and options are, and we come together to understand what's best for the person.
So it's not just you're cleared for this surgery.
No, the word
ongoing discussion. I know
clear is a term that's I talk about. Yeah, clear is a term I recommend everybody stay away from.
Yeah.
Though I do worry that it will end up being that way, as right? Like, so right now we've got these surgeon partners. I mean, Houman, I'm sure the folks that refer to you are like really into it. They believe it. They buy it. Yeah. But I'm sure, pre-op care used to be that way too, until it became, required in a way. And so I'm just saying it shouldn't be a legal thing. Yeah. And it may become that way with all the kind of regulations that are happening with the geriatric surgery verification program, or like Medicare measure happening,
We're going to talk about the geriatric surgical verification program. But before we go do that, I'm just trying to put my head around the concept of this preoperative assessment. Does every surgery that an older adult goes through need a preoperative assessment? Like, if they're getting cataract surgery, which is exceptionally low risk surgery, do they even need any of this, or should everybody, independent of what they go through this?
Yeah. So the answer is no. And I think when you asked this question in the CGA podcast too, and we actually agree, like, we have screening processes in place. So we actually have early sort of like frail screening processes. So if someone's a robust 85-year-old, to your point, but then no, they don't. They don't need. And it's all about what is the insult that they're going to withstand. So, like, to your point, cataract surgery, but it depends on how frail they are and what the risks are, right? Yeah. So what you need to do is you need to have that frailty screen in place, because we know that you can't eyeball it. 30% of the time. They did a study beautifully. I got to go back to the study, and like it was in 2005, where I think surgeons were right 30% of the time, which isn't great.
About whether or not they're frail, is that the question?
Yeah, and we're actually doing a study right now. The eyeball test. We're doing another eyeball test with video between the U.S. and Holland. We're in the process of doing this study of giving essentially the history and a video of a patient to orthopedic surgeons and geriatricians here and in Holland, and see how well they can eyeball it, and what they anchor on.
Well, I gotta ask, why Holland?
Because our researchers in the ortho geriatric trauma are from Holland.
Okay. It's not it's not that you have a hypothesis that in Holland, they're so much better at the eyeball test.
They got better eyeballs in Holland.
No, it's also a different medical system, which I think is important to look at as well, because let's be honest, there is a pressure for people to do as much surgery as possible as well. Surgeons are under the gun to, OR time is the most valuable amount of time in the system. And I think that you also had a fantastic podcast with Victor Monteri about the industrialized medical healthcare system. And I think this feeds into it very, very well as well, is that those pressures are particularly harmful to the aging population. Right?
Yeah.
So that's the other part of this element is you need screens in place, you need to identify the right patients, and then you need to do the more extensive evaluations. And that's what we've done in our system.
And just to make explicit what you were just talking about in the podcast with Victor Montori is that there's a potential, and what's happening is beyond potential. It's happening now, the industrialization of our system. And within that industrialization, the surgical time is one of the most valuable commodities for making money for each healthcare system. So there's a tremendous profit incentive. And we are one of the checks on that system. And we can be agents of change.
Checks or cogs?
We're both. We are cogs. We can be checks.
We're strong cogs. Eric, we're strong cogs.
So real quick. So all older adults in your system, we're going to go to surgery? Do they get a frailty screen?
Yeah. So or on the orthopedic side, when they come to see the orthopedic surgeon, they get that quick sort of FR. We've sort of melded all these different tools. We just happen to use the frail screen that John Morley came up with a while ago. And primarily it's also primarily because it was trying to get another screen into a busy surgical clinic is hard, and that one was relatively easy to train everybody to do. And we also tested it in our hip fracture population, and it did a great job of separating robust from non-robust, but didn't do a great job of separating degrees, like from pre-frail to mildly to severely. It didn't do a very good job of separating frailty, but it did isolate the robust patients really well.
And that's not, the frailty screen is not should I or should I not do surgery. It's should I or should I not do a more comprehensive geriatric assessment.
Exactly.
Get the geriatrician involved.
Exactly.
Vicky, do you do a similar thing? Or how do you think about the preoperative assessment in older adults?
You know what's so funny? I feel like Houman and I are both thinking, correct me if I'm wrong, Houman, but in my mind, it's like, oh, this is such a Trojan horse to do the CGA. Like, this is exactly. And so when the Geri fellows called me, I'm like, hey, oh my gosh, I have to start a pre-op, clinic or, how do I do it? I was like, look, this is all just so that you can do a geriatric assessment on the patient. And so however you want to couch it, that works for the surgeon, do it. So for me, what I like to do is say, look, these older adults, they can have their high risk of delirium. And if you do the delirium, all the things that can cause delirium, it's essentially a CGA, right? So do hearing, vision, cognition, right? Geriatric syndromes. So I do the delirium screen. That's my delirium assessment and how to optimize potentially. And then a huge component of what I think is important to talk about is the goals of care. What's the surgical goal here? How does that fit within the bigger picture of this person's life?
So why do you want the hip replacement? People just don't want the intervention. They want the outcome. Maybe it's so they can golf again, kneel down to be with their grandchildren.
That's exactly right. Yeah.
But it's also important to do that assessment because if before they weren't getting out of bed at all.
I've had patients where I'm like, hey, what are you hoping to get out of this intervention, this surgery? They're like, oh, I want to run a marathon again. I'm like, but this is not even the surgery related to, that's not going to get. So then I'm like, hey, surgeon, colleague, this is what they've told me. Yeah. I think we need to have a group conversation about You know, I mean, and the other pitch that is like, hey, you know, you're getting knee surgery. Great. It's not going to kill you. Let's talk about ACP. This is the perfect time
Advanced
to
care
talk
planning.
with your family.
Advanced care planning.
Yeah,
Can I
sorry.
Not the American College of Physicians.
Sorry. No.
right.
Yeah.
So I'm hearing a lot of concepts here, and you reminded me of another that has gone unsaid, but I think I'll say it. Comprehensive geriatric assessment is one sort of framework. I just heard advanced care planning is another sort of framework. I heard frailty, pre-frailty, robust, different levels of frailty. And also what you just said about like what their goals are reminds me of the 4Ms framework and the what matters most. And I wonder, it's a lot of frameworks for people to hold on to. And I like how you're linking them conceptually. And I also just want to make sure our listeners don't get lost in this, you know, in all these concepts. Yeah. How do you think about the 4Ms, or do you, in relationship to preoperative assessment?
Because the 4Ms kind of makes us more accessible, right?
Yeah, like I think that was the goal. Is like,
so
we have all these concepts. Let's simplify it for people.
So,
4Ms.
Yeah. But to be honest, I think 4Ms is geriatrics for non-geriatricians, right?
Yeah.
I mean, honestly, from my perspective. The other thing I would say, and you know, I'm a little controversial, but I'll be honest with you, like.
We like controversy.
Sorry.
No, I love it.
This is going to be on our TikTok.
4Ms, so 4Ms is a wonderful way to try to sort of dumb it down for non-geriatricians, and that's great. And I love it, and I'm all about age friendly, and I'm all about bringing about the domains of sort of understanding and aging that we need to pay attention to. But I would say this, and Vicky, and maybe you can back me up on this a little bit, is
always
when it comes to surgical, and maybe this is the surgeon side of me coming out, is when it comes to going under surgery, you need a lot more granular sort of assessment, because this is not like this could ruin your life if someone, my point to you, it's like saying there are times you need an MRI and there's times you need an X-ray, right? And surgery is one of those things where you need a very granular idea of what your physiological reserve is, especially in the context of aging. And it brings me back to that sort of my early experiences as a surgeon, where everybody sort of just had this. Sorry, I know it's a little bit rough, but it's true. They had sort of a sort of mercenary approach. I grew up in a world where there were a lot of people from, like, you know, they used to subscribe to these mercenary magazines, and they had this slogan that said, shoot them all and let God sort them out. And that approach to surgery is not correct. Right. That is not the way to go about it. And also, with all due respect, the 4Ms just doesn't cut it. Yeah. Like, the 5th M matters, but even more than that, you need an actual person with sort of rigorous understanding of aging versus disease to know whether your blood pressure lability is due to bad blood pressure management, or is it actually sort of advancing cardiovascular frailty and stiffness that is causing this lability that may or may not be clinically relevant.
Yeah, I appreciate that spirited defense of the geriatrician's role here. Vicky, anything you want to add?
I hear you, Houman, as a legit, card-carrying geriatrician for sure. And I also want to make sure that as many older adults can get the care that they should be getting, gets it. And so
even if they don't have access to a geriatrician,
even if they're seeing a nurse practitioner, physician's assistant, family practice. Yeah.
But that's a systems issue that we can solve.
Yeah.
And we can get into, let's be honest, that's a financial issue more than I think a geriatrician issue.
That's a separate podcast. We can talk about how to increase.
I warned you guys. You guys have already brought me on, and I'm like, I can blow up a lot of things.
So the 4Ms.
I've been building these programs.
So like when we think about the 4Ms, you have mind. So it's one thing just to do a brief screening test for like a mini cog on somebody's mind. It's another to think rationally about preoperative assessment. What does it mean to have some cognitive impairment? Did they have delirium in a past hospital stay? Because that's like the strongest marker, whether or not they have delirium in the next one. Like all of those things, which is part of that real comprehensive preoperative assessment. Am I getting that right?
So Eric, I'll come back at you as a surgeon on that.
Yeah.
What do I do with these 4Ms?
Yeah.
That's the surgical approach is give me something I can use that will tell me how I can proceed with my surgery and the management of that patient around surgery. Like it's a very different mentality than the sort of the more medical approach where like if you're approaching a hospitalist, the 4M 5M approach may be more helpful and it's gentle and it's sort of more it doesn't insult them and sort of gets them going down the lane. But when it comes to surgery, you got to get surgical. And when they get surgical, they want to be like, dude, what do I do? Like, tell me what needs to be done for this person. That's the surgical approach. Yeah. And it's very different. And the truth is when people are that abrupt, you really need the strongest granular assessment to give them a very clear idea of what to do. Because if you give a surgeon 4Ms, they're just going to like look at it and think of it as check, and move on.
Check. Right. Frailty assessment, check.
Right. Yeah.
So then what do you do? So you do a frailty assessment.
I'll push back.
Please. We love disagreement. We welcome.
You know, I'm in Texas now. So, I'm not sure that's entirely true. I mean, you have protocols, right, that you can follow. It's not necessarily a check, right? Like ultimately, Houman, you're like, oh, yes, this person's frail. This is a percentage or this is a thing. So then you can say like, hey, based on this is your likelihood of risk of having a bad outcome post-op. So I think it's still, while we want to make it sound, I guess my concern is like, while we want to make I am pro geriatrics for sure. Yes, we should all do fellowships if you want to do geriatrics, so on and so forth. But I don't want it to be overcomplicated. It doesn't need to be for most cases. And my concern is then we make it unaccessible to people. So it's like, you do what matters most. Okay, well, if, somebody says, I want to, be able to do a marathon again, and the surgery is not going to accomplish that, then no, you're not having surgery. We're going to do something else, right? If they have a high delirium risk, okay, we're going to have a conversation. You okay with that patient? We're going to proceed. Like, this is what might happen. Yes. Okay. Well, we're going to set measures in place to, prevent delirium from happening. Or if delirium is happening, then we're going to put in all the things that we can do to minimize bad outcomes from this patient. Kind of like, so I do think that, that with the 4Ms, yes, it's not like very granular, but we can still have actionable items come out of that assessment.
Houman, retort.
So the problem with that from a surgical perspective is that you can give the surgeon all of that and they're going to come back with, so can I operate on them or no? And sorry, I feel
like I can answer that for the most part, though.
But what I'm saying is that's probably what they're looking for.
Yeah.
But in all fairness, as a geriatrician, for me to answer that question with sort of more certainty, I need a comprehensive geriatric assessment to get a sense of where their deficits are and whether those deficits are going to put them in at harm for the type of insult that is planned for them. I'm not, and don't get me wrong. I'm not saying the 4Ms are wrong. And I'm not saying, and also maybe, and the robust 85-year-olds, like there's certain pathways we need to put in place, right? There's certain things that need to happen. Like the 24-hour opiate dosing has been well known. Frank Sieber published it like years ago, but it's not well known to everybody. But there are other fine-tuning things like the prostaglandin mechanism of free water excretion and the collecting duct may not be something people will know, and they don't realize that NSAIDs, right? NSAIDs and all these things around surgery can be a lot more harmful than you think. Toradol may not be such a safe med around surgery in older patients. And that level of detail and understanding is something that I think also gives us a little bit of credibility. Like, dude, you have skill, I have skill, right. and the idea is together we can take care of this person. And Eric, I actually agree with you when you said the very severely frail probably the reserve is so gone that probably your dosing is not going to make a difference, and your robust probably with just a simple checklist of don't do dumb things due to basic ACing changes will work. You don't need the whole CGA or a geriatrician involved. Yeah. But it's that middle group. It's that sort of moderate to severely group and that sort of mild to moderate group where that's where the geriatrician has its value. And the idea of where do you deploy geriatricians? That's where you deploy geriatricians. Like, that's where the value is. And then other people can do the rest. And by geriatricians, by the way, we are teams, like, geriatric MPs, geriatricians, like people who are, my point is that my answer to everybody is, and especially is when it comes to geriatric, I'm like, how rigorously do you know the physiology of aging? And do you know it well enough that you can make medical decisions based on that understanding so that you can have different clinical outcomes in the person in front of you? Like, if we asked that of a pediatrician, nobody would question that a pediatrician was appropriate for children. Imagine having doctors who know nothing about normal growth treating kids. Like, come on. Like, there's a point where we got to draw the line and say that, listen, the knowledge base and skills of aging is required and needed. And if we can develop cath labs in every hospital over the course of 5 years, I think we can solve the need for training geriatricians in the country. And with virtual care, we can find the transition to get there. I'm tired of these naysayers, because I've done it. When I went, sorry, I shouldn't be saying this, but 13 years ago when I went into my hospital, there were no geriatricians. They didn't even know geriatrics was a specialty.
Yeah, when I trained there, no geriatricians.
That's right. There was no geriatrician. They didn't even know. Now they can't imagine functioning without geriatricians.
Right.
All right, I got a question. This is all, I love your passion. It makes a lot of sense to me. But do we have any data that doing these comprehensive geriatric assessments before surgery improves outcomes?
Yes, thank you for asking, Eric. I knew you'd be asking me. All right, so which data do you want? The first data I did 10 years ago in my group was we showed the utility of mini-cog in fracture patients. When I first did the mini-cog on the inpatient side, all the geriatric, everybody, the neurologists want to kill me. Why are you doing a mini-cog in the acute setting? I'm not using it as a dementia screen. I'm doing it as a cognitive stress test on my patients to get an idea of what their level of cognition is.
It's like the treadmill test you're using.
That's right. And guess what? We published that it's a great test for assessing cognitive vulnerability in delirium. But we also sort of threw in there the fact that since we got a geriatrician, our mortality rates dropped to 18% and our delirium rates dropped to 10.5%. They used to be 25%. And now there's a recent study that came out of the UK, which showed that if you get a geriatrician involved in trauma patients, the mortality significantly decreases in the care of those patients. Oh, well, you did it in, hip fractures, but can you do it, or like, can you do it in this hospital? Can you do it like everywhere in the world? This has pretty much, orthogeriatrics has demonstrated that you bring the concepts of geriatrics to this. The other one is then we did elective joints. And then with elective joints, what we showed, and by the way, I've been very lucky, and this is the interesting, I've been very lucky because the orthopedic surgeons I work with are very clever and very sort of resourceful. They have the resources, right? But they actually looked at, if you saw a geriatrician within 90 days of the surgery, your ED readmissions drop. And we published that, and that was with Antonia Chen. And by the way, the problem is most of this literature is in the Journal of Orthopedic Trauma. It's in trauma, it's in injury, it's in all the surgical journals. So a lot of people may not be as aware, but I got to be honest, it's just easier to get this stuff out there in the surgical journals. And the resources that people have on surgery to show these outcomes are greater. So I'm in the middle of the authorship.
Surgery. It's fine.
Huh?
I was going to say, I publish all my stuff in surgery journals. It's fine.
Yeah.
That's your audience,
Yeah.
Right, that's your audience. Vicky, what evidence would you add for prehab and other elements of the comprehensive geriatric assessment?
I really want to be I'm told I love Houman's energy. So we recently did a systematic review with the ASA group and looking at prehab. So I'll talk about prehab. So it's
American Society of Anesthesia.
Thank you.
Go ahead. Go on, Vicky.
I was forgetting.
Yeah.
Yeah.
What is prehab?
So prehab is essentially, the idea is for elective surgical cases, you can prehabilitate, which is like kind of like rehabilitate, but before they decline, and basically build up or optimize either their, functional level, their cognitive level, their nutrition status, so that after surgery, when they take that hit of surgery, they have more kind of reserve to, I guess, use up, and that's, I guess, what I think of when I think of prehab. So the literature's been mixed. Everybody's got a different definition of prehab. And so it's kind of left a question as to like, does it work? Does it not work? And which patient population versus not. I'm always in the pro prehab world. I also think that everybody would benefit from a geriatrician, right? We can always find something to help and optimize. So that's the short answer for prehab. It's plus still pending a really good large study where there's a good definition of prehab.
And let me ask you this, because it does feel like that the tide is changing as far as surgeons, because I feel like there is a lot of interest in things like frailty from the surgical side.
Yeah.
I've started to hear about this geriatric surgical verification, kind of like this age-friendly movement that we're seeing everywhere, but in surgery. Do you feel like that there is this change in the...
Absolutely.
Yes.
Yeah, absolutely. And I'm happy to speak to that. So the geriatric surgery verification program was developed with the American College of Surgeons with the support of John A. Hartford. Back in 2019, they started right before the pandemic. And the idea here was that, hospitals that applied to be a geriatric surgery verified program would need to meet certain criteria, really around pre-op assessments, what we've been talking about, making sure what matters most is asked, making sure we have function assessments, physical like PT assessments after surgery, before surgery when possible. And so now we're up to 80 hospitals that have signed up for the geriatric surgery verification program nationally. And it fits very well with the CMS medical care measures and the 4Ms as well. But their big sell is, hey, we're going to help your hospital system meet this Medicare measure. We're going to help decrease the rates of delirium post-op. And I think that really the most awesome part to me about it is this requirement to have goals of care discussions with patients and their family members, making sure advanced care planning is done. And yeah.
That's great. Thank you.
We'll have a link to the geriatric surgical verification website, the great website I was looking at yesterday.
Houman, can I also do a quick pitch too? So ACS has NSQIP, the National Surgical, I don't remember exactly, NSQIP. Yeah. And so the folks that did GSV, they've put in some outcomes that older adults would be interested in, like given, all these risk factors you plug in, after surgery for this type of procedure, what is your likelihood of going to a skilled nursing facility or a nursing home after? Yeah. So they've got
a prognostic
some cool
index for for the pre-surgical.
Yeah. Conversation for older adults. Yeah. So that's been really neat to see.
We'll have a link to that on our show notes too. Houman, you were going to say something?
No, I think what I would say to people is, having sort of been the first academic center to try to implement GSV, is don't be discouraged. I mean, I think the first pass of GSV has a hugely demanding sort of bar. And may I say that, the only feedback I would say it's slightly too academic. I think that a lot of the backlash is that it makes it look like that there's all these incredibly sort of demanding, resource-intensive things that you have to do. While in reality, what it just boils down to is you need a geriatrician to know about aging and disease, and then you can use the GSV outline to sort of move the bar forward in terms of your protocols and outlines of your institution so that older patients can be assessed and risk stratified correctly with the right perioperative and post-operative management so that they can have better outcomes. And GSV is done in this almost exhaustive sort of, I think it's...
There's a mini version now. There's a mini version now. There's a mini version.
As someone who's actually been involved and I'm the one that's advocating, but I would say, I think the GSV is fantastic, but it's exhaustive in the sense that I think people should look at it. I would say invest in the people who want to actually focus and care about older surgical patients and use GSV as an outline And then the nice thing about it is that it gives you credit if you put the resources in place. And that's a whole nother podcast is the finances of all of this and the industrial complex of all of this. But having said that, Vicky, I think it's very important to be positive that surgery is actually a space which is a revenue generating space where Trojan Geriatrics is exactly the term I use, Vicky, has demonstrated its efficacy and its clinical validity. And I think we should use that in the United States as one of the waves which sort of we can lift geriatrics up in our country. I genuinely do. I feel like it's a fantastic opportunity.
Okay, well, Alex sets up real quick. I have one last question. If you had a magic wand, you can change anything that happens around the pre-operative assessment for older adults or the perioperative management, what would you use that magic wand on? One thing that our listeners could think about. Vicky, go to you first.
I feel like I'm going to use Houman's line is everybody needs to get geriatricians in their hospital doing pre-op assessments. Did I get it?
Yeah. So Eric, I would answer that because recently I had a procedure, and I guess when you come out of anesthesia, you're very lucid. But for me, my new mission is I've reached a stage where I want every older patient to have access to someone with the knowledge base and skill for aging so they can get the care they deserve. And that's
beautiful.
That's really it.
That's much better. Last time I had a procedure, I think I was talking about surgery in the sushi.
Sushi.
That's much deeper than my thoughts about
he was talking about sushi.
Yeah, that's not as deep. Well, Alex, you want to finish us off?
Okay, here's a little bit. Ahora. Difícil de entender, me suele suceder que tan solo en el futuro puedo ver felicidad, porque no puede ser ahora.
Vicky Houman, thank you for joining us on this GeriPal podcast.
Thank you for inviting us. This was fun.
Absolutely.
And to all of our listeners, thank you for supporting the GeriPal podcast. We'd like to say a quick thank you to everybody who's donated to the GeriPal podcast to support us in the continued work. And a shout out to everybody who's donated more than $250 in the last year, including
Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulsky, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones, Kate Mesrich, Jen Hopping, Ashad Abid, Michael Bordowski, Asher Edwards, Susan Nelson, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Brangman, Elizabeth Chung, Paul Amatelli, Brian Castle, Victoria Brond, Susan and John McFadden, Christopher Heck, Amish Moji, Matt Schuster, Carrie Hagan, Lloyd Woolstat, Carrie Levy, Marnie Fetzer, Ron Sabar, Stephanie Gabatuller, and Patrick Lally.
Thank you very much.